Hi, everyone. Welcome back to the Breast Cancer Podcast. Hello, I'm your host, Dr. Deepa Halaharvi, a fellowship trained breast surgeon, and also happen to be a breast cancer survivor, thriver, and a warrior, living my best life. As you know, breast cancer affects millions worldwide, touching lives in a profound ways. Whether you're someone facing a diagnosis or a supporter seeking information or just eager to learn more, this podcast aims to be a beacon of understanding, hope, and empowerment. I'm here to talk about all things breast cancer, from surgery to survivorship, as well as high risk for breast cancer to metastatic breast cancer. My goal is to provide you with reliable information, share inspiring narratives, and foster a supportive community. I know firsthand the challenges breast cancer diagnosis brings. Throughout this podcast, I will give you strategies to handle difficulties that arise from cancer diagnosis. We'll have insightful conversations with medical experts, researchers, survivors, caregivers, and advocates. I will tackle topics that impact our lives as cancer survivors. My goal is to educate you and empower you to live your best life. I definitely have. Well, let's get started. Hi, everyone. Welcome back to the Breast Cancer Podcast, as well as the Breast Podcast Ever. Dr. Pankaj Tiwari is with me here today. And we wanted to just come on here to talk about implants and tissue expanders. We like throw out these terms all the time. And so I wanted Dr. Tiwari to actually show us what a tissue expander looks
Well,
like.
we brought props.
Yes.
I thought we'd talk
Yeah.
about
Yeah.
how they work because I think
Yeah.
it's a really kind of cool piece of engineering that some guy who's much smarter than me came up with. And so this is a tissue expander. I don't know if people can see it okay. And
Yeah.
what this essentially does is it, like the name implies, expands the tissue. And so what's all this stuff on there? Well, there's two. This is a very new generation tissue expander made by a company called Sientra. And you can see it has two ports with it. This is what we actually use in the operating room. It has these two ports and it has a series of holes at the bottom. So one of these ports allows us to fill the tissue expander with normal saline salt water. The other port lets us remove any fluid that may be around the tissue expander. So Dr. Halaharvi does a wonderful mastectomy, but there's always space. And that space can fill with fluid. That fluid can become infected. That's why we use drains. So this allows us to not only maybe limit the number of drains that we use, but allows us to remove any fluid that may be in the area to limit the chance for an infection. So it's a really interesting way to do tissue expansion. Ultimately, this expander creates a home for the implant. That's the way I like to think about it. Because the implant, this is an example of an implant, doesn't really do anything. It just sits there. It sits in the space that we've created. And I like tissue expanders because it really is a slow and steady wins the race type of approach. We're very carefully creating a symmetric space for both sides for the eventual implant reconstruction. And it allows us to have some shared decision making because we can decide together what the right size is.
Yeah.
Maybe it's 300 cc's, maybe it's 350 cc's, whatever that is. We then pick an implant that matches that type of volume. So that's how we do it.
I have a question for you. So this sits underneath the skin. So a breast surgeon does the mastectomy. So I always say breast is like a pillow in a pillowcase. So we remove the pillow and there is a pillowcase.
Yeah.
And so Dr. Tiwari or his team, they put this underneath the skin. What are these tabs for? There's three tabs
Oh,
here.
great question.
Yeah.
I should have. Great question. You're genius. So, one reason why I like the tissue expanders is it allows me in a very consistent and reproducible way to attach these tabs, these little tabs that Dr. Halaharvi pointed out. There's three of them, one at each side and one at the top. So I can put the tissue expander exactly where I want it, and I can suture it with a suture that's actually a permanent suture to keep it from rotating, because what you don't want is it to rotate. One problem that I have with direct implant reconstruction, we were just talking about that, is an implant doesn't have any tabs in it. And the reason is that if you put tabs in an implant and the tabs break, because an implant is in for a very long time, now you've got this foreign body and it would never get approved by the FDA. So this allows us in a very consistent way to position the tissue expander so that when we expand it, create a home, we can swap out one pillow for the other pillow and we preserve the pillowcase. So super important point about how to use those tabs at the time of the operation.
That's really good. And now you said you do cover this with something,
Yes,
and what is that
also
called?
very important. So we use what's called an acellular dermal matrix. So what does that mean? Well, you can't just put this piece of plastic, essentially silicone-based material, into somebody. And like I said, there's a lot of fluid that develops.
Mhm.
So you need some kind of biological interface between the tissue expander and the overlying skin to, again, limit the chance for fluid, limit the chance for an infection, and to allow things to heal. So we wrap this like a burrito in what's called a cellular dermal matrix, which is tissue derived from other people, but it has no cell element, so you can't really reject it. And it allows us to create that biological interface between the tissue expander, which we completely wrap the tissue expander with this acellular dermal matrix, and the overlying skin and soft tissue. So it's really been a big change in the way we do things because it
Mm.
allows us to now put this above the muscle, not below the muscle, which we can also talk about. A lot of advantages to placing the tissue expander above the muscle and not below the muscle. But technology with these acellular dermal matrices has really let us do this in
That's
a
awesome.
way that we're not doing more invasive operations. We just did a podcast with somebody in India, and they only recently had access to these acellular dermal matrices. And because of that, they end up doing a lot more surgery on the patient, which I think we can avoid, and that's good.
Yeah, that's wonderful. No, this actually, it's a good visual for people to see, what and how often do you fill these with the saline?
Usually, starting about 3 to 4 weeks after the operation, we'll
Okay.
do it every week, every other week. There's no real
Yeah.
timeline, but on average, it's every week to every 2 weeks. On average, it's 3 to 5 expansions. So if it's every other week for 5 weeks or for 5 expansions, that's 10 weeks.
Yeah.
So it is a process to go through the expansion, but I do think that we can do it in a way that's very predictable, very consistent, doesn't cause a challenge to the blood supply if we're doing a nipple sparing
Yeah.
mastectomy. So it allows, I think, the fewest potential problems.
Yeah. I will say, as someone who had reconstruction where this was placed underneath my muscle, which is very painful, I'm glad we don't do that anymore.
Yeah.
So the pre-pectoral implant-based reconstruction is way better. At least personally for me, it was so painful. I know that's how they did it back in the day, but so okay, so this stays in for a couple of months, about 3 months, you said, right?
3 months total because it'll take about 2 months or so to expand.
Yeah.
Then after about a month of just letting things relax, we'll take a patient back to the operating
Okay.
room. So on average, about 3 months later, we'll replace the
Yeah.
tissue expander with an implant
Yeah.
or a deep flap sometimes, and that's known as a delayed immediate reconstruction. That's a whole separate
Right.
conversation, but
Right.
yeah.
And what type of implant is this?
So all implants have a outer silicone shell. So even saline implants that are filled
Okay.
with normal saline, their shell is silicone.
Mhm.
But most of the implants we use for reconstruction are silicone-based implants in that the internal part of the implant is also silicone-based. And I think that silicone implants, they are safe, but there are considerations. You know, these are not permanent devices. They have the ability to, over time, wear and tear. So if a pet jumps on you or an airbag
Mhm.
deploys, it's not going to rupture. It's more of a wear and tear over time. So on average, it's about 1% per year, so 10% at 10 years. We don't really use textured implants anymore. So the
Mhm.
difference here is this
Yeah.
has a smooth surface, this has a textured surface. Why the difference? Well, the thought was that a textured implant would sort of stay where we put it. There'd
Mm.
be less movement.
Yeah.
It has more of an anatomic shape to it. So these were known as the gummy bear implants. And I think the thought process was very, very understandable why these were created. The problem with these is that there has been an association with ALCL lymphoma.
Mm.
And
Right.
there's been an FDA registry on breast implant associated ALCL lymphoma type of blood cancer. So in this day and age, we're not really doing textured implants anymore
Yeah.
because of that concern. The silicone implants that are smooth based don't have the same incidence as the textured implants. There's something about the texturization process that has an increased inflammation component, which then I think leads up to ALCL lymphoma. So smooth implants, not the same risk. Very common for us to use them in breast cancer reconstruction if we're not doing a deep flap. Are they safe? In general, I think they're safe. There are definitely considerations that we always talk about as we go through our consultation, but that's a good summary on using tissue expanders, how they work, and then using implants.
And the one common question I get asked is if these need to be changed out every 10 years.
Yeah, great question. I'm
Yes.
so glad that you asked that
Yeah.
question because I really do think that's a bit of a myth
Mhm.
in plastic surgery, not only for cancer reconstruction patients, but also for cosmetic patients. You don't have to go through surgery every 10 years.
Yeah.
You don't have to get your implants changed every 10 years. If there's no problem, there's no problem.
Right.
There's nothing that's going to make an asymptomatic patient better
Right.
if there isn't a problem to begin with. So I do think it's reasonable to see your plastic surgeon
Mhm.
to communicate if there are problems that you're having. If there is a concern in the shape, if there's a concern for a rupture, then the next step is to get an ultrasound typically.
Yeah.
But it is a myth that you have to change your implants every 10 years. That's not necessary.
Yeah. Well, thank you so much. This is really great information for our audience and a good visual. I mean, a picture is like 1,000 words, they say, right? So it's really good for people to get an idea what implants look like. So when people have questions, we'll direct them to this podcast and the video. So thank you so much for taking the time
Of course,
and
thank you.
explaining all of this, Dr. Tiwari. So until next time, hope you found this podcast and the video to be helpful on the Breast Cancer Podcast, the best podcast ever. And give us a 5-star rating if you like it and share it with your friends and family. So thank you all very much.
Take care.
Bye-bye. Thank you, everyone, for tuning into the Breast Cancer Podcast. Remember, you're not alone in this fight. I encourage you to be an active part of this podcast. Please share your stories, questions, and suggestions for future topics at my website called drdeepahalaharvi.com. And please share this podcast with others, especially if you found it useful. And please also give it a 5-star rating, if you will. Stay connected as we navigate the complexities of breast cancer. Until next time, take care and keep shining brightly. Disclaimer: this podcast is not intended for complete medical advice.